That being said, without any further ado, I'll turn the floor over to Dr. Leo Brandel.
Thank you very much, and welcome everybody. On behalf of Dr. McGregor, Stu, and myself, I would like to thank you for joining us to hear about a little bit more about global hemostatic tests. First and foremost, we'd like to thank the sponsorship of and the great help of Sophie, who has been instrumental, as well as to Ms. Enda Brennan, who have both been instrumental in organizing this together with Cisco and WebEx. Just a few more comments in terms of housekeeping. We will probably try to hold questions until the end, and as we did in our previous sessions, we will go from the Western Canadian centers to the Eastern ones, one by one, to see if there are questions that are present. So I was talking to hopefully gain a few more minutes until the last centers can join in for our second of the four education and CPT-Gen sessions. I think I'll have the pleasure to introduce our speaker now. Now, Dr. Rivard really doesn't require any particular introduction. He's an internationally renowned investigator and clinician scientist in the realm of hemostasis and thrombosis. He is a clinical professor at the Department of Pediatrics at Université de Montréal. He is Chief Division of Hematology Oncology at Saint-Justine, Montréal, and Medical Co-Director of the Hemostasis Clinic and Quebec Reference Center for Coagulation Inhibitors. He is also Medical Director of the Clinical Hemostasis Lab at Saint-Justine. And if it was for me to try to summarize his CV, we will be here within the next hour or so for sure. So it's extremely humbling and also a tremendous honor to have him giving this lecture today. Thank you very much, Dr. Rivard, and looking forward to your session. Thank you.
Thank you very much, Leo. The technology that I will be presenting today was already old when I was young. Now it is getting younger while I'm getting older. I don't have anything to declare in terms of conflict of interest. This is my learning objective. In a nutshell, I will briefly talk about TEGS and LOTEM for investigation of bleeding disorder and for the management of congenital and acquired bleeding disorders. Hemostasis is a happy balance between clotting and lysis. When there is less clotting and or more lysis, there is bleeding. When there is more clotting and or less lysis, there is thrombosis. Hemostasis is constituted of three major families of players: blood vessels, platelets, and plasma proteins. What can we do in a clinical hemostasis laboratory to assess the contribution of those different players? Blood vessels, difficult. Well, we still have the old-fashioned in vivo bleeding time that, of course, will give us some information on the direct and in vivo relationship between platelets and or plasma proteins. Of course, we will learn something about the circulating substances that may have to do with the tonus of vessel, and namely things like endothelin or prostacyclin. Also, we can, of course, learn something about some proteins that are present in the Vipo bodies of endothelial cells, namely von Willebrand factor, TPA, and pi. And upon the stimulation with a pharmacologic agent like the DDAVP, we can have an idea of what can be released out of those storage pools, namely the lipoparity buttons. As for platelets, we certainly have platelet counts, PFA. We have morphology, optical optical microscope and electron microscope, namely for looking at the delta granules. Of course, we can do some aggregation, and again can be done with the light transmission aggregometer or impedance aggregometer. Now, as for plasma proteins, we have a great number of assays with many specific substrates, namely fluorescent and or chromogenic assays. But what we would like to have most is some kind of a system test that could look at all these players in their semi-natural environment, acting on each other and contributing to formation of clots. And TEG, ROTEM, as well as thrombin generation assay is probably as close as we can get to this type of assay. Now, let's briefly look at TEG and thrombin generation. TEG was conceived and developed in the 1940s and first presented in publication in 1948. Now, what they were seeing way back in 1948 is very similar to what we're seeing now, with, of course, now the advantage of having the support of computers. Now, looking now at TEG, well, over the years, there have been several generations of this instrument. It happens to be the most recent generation. And this equipment can be hooked through to any lab computer with the proper software. One can generate curves that depict the reaction that we're looking at. This instrument has two channels, and for each channel there is a holding block that is thermostated, and in this block sits a disposable cuvette, and in this cuvette one can put any kind of reagents that one wants to use for checking coagulation or fibrinolysis or folds. And this, and then blood is put in, and blood, and in this blood drops a pin that is hooked to a torsion water. And as fibrin starts to get produced, it produces a linkage between the stationary pin and the moving cup, and this is transmitted through the computer and presented in the format of tracing. And of course, there are different nomenclature to describe what one sees. Here, one is looking at R, which basically represents the time between the initiation of the reaction and the initiation of thrombin generation. And here, of course, the alpha angle is give an idea on the velocity of the reaction, and the space between the two lines, the maximum amplitude, is a representation of the viscosity or the standstill strength of the fibrins strands that are linking the cuvette and the reporter pin. Here is the ROTEM. This is a much younger generation of equipment. Very quickly, it has its own computer, its own screen. It has 4 channels. The only difference between this and the TAG is that here the cup is stationary and the reporter pin rotates. And for the rest, this is exactly the same. To make it a bit confusing, the nomenclature is different, but the principles and the information are exactly the same. So this is the mirror of one another, and what I would say blanc, bonnet, bonnet blanc. Now this is a picture that everyone has seen in the textbook. I'm not going to go through this, except to simply illustrate that here is a normal tracing, and the tracing of plasma that is deficient in coagulation factors and or has heparin or other anticoagulants. Here, of course, it depicts a situation where there is fibrinolysis. Now, TAG and ROTEM have a similar menu, and briefly, TAG can look at an intrinsic coagulation pathway, the extrinsic coagulation pathway, or have a somewhat semi-quantitative assessment of fibrinogen concentration using different reagents, but there is a way of assessing the fibrinogen level with this instrument. This instrument is also provided with a special kit that is used to assess the effect of aspirin or Plavix on arachidonic acid activated platelet or the ADP activated platelet. This is the menu for ROTEM, and basically the same. And look at the intrinsic, the extrinsic fibrinogen. The difference here is that these reagents come in the format of the kit, and this is certainly more user-friendly for one who is not a real whiz in this domain. Now, here is an example of a platelet mapping looking at treatment with COX inhibitors, here namely aspirin. So one sees the total or maximum platelet activation by thrombin that is generated through activation of coagulation by kaolin in a cup that is contains heparinase. But in short, one can see that the equipment give you a direct readout of the inhibition induced by, in this case, aspirin. And basically, one has the same kind of information looking at inhibition of P2Y12 by different inhibitors and revealed by response to the ADP in terms of platelet contribution to the tensile strength of the clot. Now, look at thrombin generation assay. In fact, the first publication that I could find about thrombin generation assay dates back to 1901. The first thrombin generation assay that was developed and was usable in a clinical lab was presented in a publication by McCollin and Rosemary Pig out of Oxford. In very short here, one collects whole blood into a glass tube, and through the contact with glass, contact activation of coagulation, and at different point in time, a subsample is removed out of the whole blood and transferred into a solution of fibrinogen that has already been standardized. So the time it takes to make a clot reported on this curve gives a estimate of thrombin generation. It's interesting to see that the shape of the curve in thrombin is very similar to what we see with our more recent assays. And here, another interesting information here. One is looking at 12 normal subjects, and one can see that there is a big difference between the different subjects in terms of the total amount of thrombin that is being generated. This here is an example where one puts in thromboplastin and, of course, highly speeds up the generation of thrombin. And here, an example of what people are using today, the assessment of the effect of replacement therapy on hemophiliac plasma. So the plasma has zero factor VIII activity, has no thrombin generation. One puts in 0.5%. This is a curve A. Curve B, 1% and 10% of normal plasma. So, interesting example of things that we are now seeing with more sophisticated instruments today. The person, to my knowledge, has contributed the most in studying thrombin generation is Dr. Kenneth Mann in Burlington, and I was able to identify 102 citations from 1926 to 2013 on thrombin generation. In 2003, that is more than 10 years ago now, with colleagues, they published a very interesting paper that they entitled, "What is all that thrombin for?" And in very short, here the thrombin generation is initiated by tissue factor, and one sees that quickly, within 2 minutes, platelets have been activated and have started to release the contents of the alpha granule. Here, one is looking at acylmectin. And as time goes on, more thrombin is being generated, and more reaction takes place, namely activation of 5 and 13, and release of 5-aminopeptide A and B of fibrinogen. To make a long story short, after 4.7 minutes, a clot is formed. And at this point, it is also interesting to note that only 4.9% of the total potential thrombin generation has been formed at the time when the clot is formed. In other words, when you're looking at the results of a test that uses clot formation as the indication of the endpoint of your reaction, well, you have in fact looked at only 4.9% of thrombin generation. And this is illustrated by this other picture where one sees that after the time that clot was formed, there is much more thrombin that is being generated, and that is what we are hoping to give us some information when we are using a system whereby we're looking at the full thrombin generation with these tests. Just here an example to show that one can combine the information of tag and thrombin generation, and one sees that there is a nice parallel curve between the tracing of clot firmness and thrombin generation. As for thrombin generation to be used in the clinical lab, the major best contribution came from Conrad Hemper out of Maastricht. And a major contribution was to pick the right fluorogenic substrate, but probably more importantly, to design a mathematical modelization of the thrombin generation, and namely the utilization of substrate. So in other words, this software allows one to, or allows the system to make constant correction for the utilization of the fluorogenic substrate in the process of thrombin generation. So this is now commercially available and user-friendly. In fact, when one uses the right reagent that comes in kit, and of course there is an equipment that is made specifically for that, but one can use any good fluorometer. Now, this is the tracing that one sees. Basically, the lag phase, the time it takes for thrombin to start being generated, the time to peak, the peak, and the total thrombin potential that is assessed by the area under the curve. Now, of course, since all these coagulation factors have well-known constants of activity and affinity, this requires only somebody who has good knowledge of mathematics to generate a mathematical model. And this is exactly what was done and published in 1994 by Ken Mann's group. And over the years, this system has been used very successfully, and we will see a few examples of this. And to be published soon from the same group, a overview of the modeling thrombin generation and plasma composition. Now, not everybody has the same opinion on the modeling of thrombin generation. And in 2012, in the Journal of Thrombus Hemostasis, a debate was organized between Ken and Mann, standing the yes position. And after a long description and explanation, he comes to his typical phrase like numerical models efficiently and cheaply allow casting for molecular fit. Man lives on the trampoline and likes on fishing. So it shows here. These models are not panacea, nor are they a replacement for empirical fishing, but they are useful thinking tools. Well, to standing on the no side, Hemker states, after also a very nice presentation, it says, present the modeling of thrombin generation system reflects what we know already, which is a lot, but fails to predict what happens in plasma. At present, if one wants to know about thrombin generation in a patient, one has to determine thrombin generation experimentally. Well, I would say here yes and no. That one here it can probably not state as firmly as it did Anchor to say that what happens in the thrombin generation equipment is exactly what is happening in the patient. Nevertheless, the point is taken. Now, global hemostasis for investigation of bleeding disorders. Here I made some statement. Global hemostatic assays have demonstrated abnormalities in a large number of congenital as well as acquired bleeding disorders of platelets, coagulation, and fibrinolysis. they can lead to a specific diagnosis, but they cannot make it. They are very useful for ex vivo assessment of the multiple known and unknown participants to hemostasis, thrombosis, and fibrinolysis. They are sometimes better than the specific test to indicate the presence of bleeding or of thrombotic risk in the given patient. They are often better than a series of specific assays for the management of complex clinical cases where the multiple participants to hemostasis, thrombosis, and fibrinolysis are in constant, rapid evolution. This is a personal opinion. Now moving to management of congenital and acquired bleeding disorder. Very recently, all of you have seen this photo published in Blood. A group of experts have probably come up with what is the best review on the global test for management of hemophilia. And here is a nice example of the tracing from a patient with severe hemophilia. And after correction with 100% factor VIII. The same group looking at plasma with inhibitors. Of course, the black line here shows strictly nothing happened. There is no factor VIII activity. And if one gives, here I'm missing one. Anyway, I missed this one here, but if one gives 75 units per kilo of FEBA, there is a clear correction. Here it is. And if as the effect of FEBA has started decreasing, one comes in with 70, there is a new burst of thrombin generation and generation of a solid viscous clot. So from the author, I quote, in patients who develop inhibitory deficient clotting factor and in whom the bypassing agent are required for hemostasis, these assays offer the opportunity to determine the laboratory response of these intervention where traditional coagulation assay cannot. There is a paper soon to be published in Hemophilia, Generation After Thrombin, as an objective parameter of treatment response in patients with severe hemophilia A and inhibitor. Here, coagulation is initiated with tissue factor at 1 picomolar concentration. There is a subject with severe factor VIII deficiency. And in short, I don't know how well you see on the screen, but this is a normal tracing. And the solid black line here is with the replacement with the factor VIII, there is strictly no effect. But if one gives APCC or more APCC, there is clearly some thrombin generation. Now, one looks at acquired hemophilia with a type 2 inhibitor and a similar presentation here, but one sees that here factor VIII is very effective in inducing thrombin generation, and APCC is clearly less effective than factor VIII. Now, looking at another subject with acquired hemophilia and higher titer, here clearly factor VIII is not effective, but a higher dose of APCC induces a high burst of thrombin generation. Now, what is the relationship with this and the clinical efficacy? This is the question that the authors of this paper raise. For the time being, there is relatively little data to say that the nice tracing that we see are nicely predicting the clinical response. Now, looking at modeling of thrombin generation here, 44 subjects with severe hemophilia, for whom all these factors were actually tested in their plasma. In this mathematical model, thrombin generation was induced by tissue factor at 0.5 picomolar, and factor VIII was adjusted at 100%, and the half-life of factor VIII was adjusted at 2.2 hours. Now let me take you through this somewhat complex slide here. This is a nice original way of presenting data in a somewhat three-dimensional fashion. On the vertical axis, one looks at the lag time. On the horizontal axis, one looks at the maximum rate of thrombin generation. Now, the color from blue to red indicates the peak thrombin generation. So let's go and look at this. Right after injection of 100% factor VIII, one immediately sees that amongst 44 subjects with severe factor VIII deficiency, they clearly don't all behave the same. And for instance, here at the bottom of the right lower corner, one sees the red dot, and this is clearly indicating there was a high level of thrombin that was being generated. And the lag time was short, and the maximum rate was high. But at the same time, if you look at this fellow here, also severe, also equally in silico, treated with 100% factor VIII, and yet much less thrombin generation, a longer lag time. And this corresponds very well to another study that we have done with this group, where we actually look at the thrombin generation in a wet lab, and we see the same. See clear that, of course, we all know this, but all severe hemophiliac do not bleed the same, and this probably has to do with the other factors that are involved. So a nice way of presenting this reality. Now, quickly here, looking at a combined system, where one looks at thrombin generation in the TEG system and an effect of TPA. In short, this is to show that out of 5 normal people, they are all different. Clearly, this one generates a stronger clot than this one, and clearly this one is more resistant to a TPA than, say, this one. Now, looking at bleeding, the rare bleeding disorder, here a case of hypofibrinogenemia, here a case of mild factor 13 deficiency, in black, in green pre-treatment, and in black post-treatment. Here is a child with a Glanzmann thrombasthenia, and clearly one sees that the strength of the clot is very weak. Now, here is another interesting case. You're looking here at a normal horse, and you're looking here at a Glanzmann 18-month filly. You can see that here the MA, or the strength of the clot, is not as good as in a normal horse. And of course, if you do the classical thing, look at clot retraction in whole blood, nice clot retraction in this normal horse, and a very nice retraction of this clot in a PRP, where one looks at the Glanzmann horse, no retraction, and spinal fact there is a big clot, and no retraction in PRP. Now, here is a very sophisticated instrument that was built in my basement, and the intention was to have an equipment that could assay the effect of cold on coagulation assessed by TEG. So there is a refrigeration unit, and these are thermostated TEGs. And here is a normal person. Look at the R. The temperature is 37. We drop the temperature. We drop the temperature. Drop the temperature to 20. Drop the temperature to 15. Okay, now let's look at the mild hemophilia, moderate hemophilia B at 37 and drop the temperature to 15. And now let's give him some benefits. 25 units per kilo at 15 degrees and raise the temperature and finally put him at 37. Soon to appear in hemophilia and ice age concept. Good reading. Quickly looking at the generation of thrombin across pregnancy, and I will be quick here to simply illustrate by this tracing that pre-pregnancy, early in pregnancy, and in late pregnancy, clearly evidence of increased thrombin generation. Another interesting, somewhat old now paper, looking at 37 postpartum hemorrhage and 54 normal and 54 normal delivery. Here, one evaluated the correlation between the height or the deflection when one is assessing fibrinogen, and there is a clear their sensitivity is at 100%, and the specificity is 85% when one uses this reference number. So their comment was Rotem might be helpful in guiding fibrinogen transfusion during postpartum hemorrhage. This is a study in cardiac surgery, and very quickly randomizing 100 individuals for management of replacement therapy with point-of-care testing, that is here Rotem, and platelet aggregation with impedance. And one looks at the results in red, those that had blood replacement therapy according to standard approach and using standard coagulation test, and those managed with point of care, namely Rotem. And there is a clear difference in terms of decrease bleeding at 6, 12, and 24 hours. And here, this is a Kaplan-Meier survival for those managed with this. This is the standard approach, and the POC in blue. So apparently, an advantage for survival. This is, one cannot make this kind of presentation without referring to Cochrane. And this is the typical Cochrane approach, starting with 2,560 papers coming down to 9 that were evaluable. And their summary is the following. TEG or Rotem guided transfusion algorithm appears to reduce the number of patients with transfusion requirement in a cardiac surgery setting, but failed to show either a reduction or increase in mortality or the length of stay in ICU and hospital. Well, there is currently moderate to weak evidence to support the routine use of TEG or Rotem in adult cardiac surgery or liver transplantation population in order to monitor and reduce immunotherapy. Now, quickly here, so this is of interest, looking at using thrombin generation tracing for monitoring reversal of the bigatron. And in short here, you can see with no treatment with PCC and with APCC and with factor 70. So it looks like one can reverse, at least in this system, the effect of dabigatran at standard dose at high plasma level concentration. The same with rivaroxaban. If one does not use anything, if one used APCC or PCC. So it looks like in both reversal of rivaroxaban and dabigatran, APCC and PCC are comparatively effective. In very short, looking at standardization of TEG in 9 laboratories from Canada, Denmark, Israel, UK, and USA using TEG and ROTEM, centrally supply PRP and pool of normal as well as hemophilia plasma. Somewhat deceivingly, the interlaboratory variance is more than 10%. To be published soon in the Journal of Thrombosis and Hemostasis, a report from the SSC of ISTH, and the conclusion is that either TEG or ROTEM may be utilized. For clinical care, we recommend the use of the intrinsic pathway activation with kaolin, and we cannot, for the time being, endorse any specific method for extrinsic pathway activation. In conclusion, even if we have chromogenic substrates for specific testing of every enzyme involved in coagulation and fibrinolysis, even if we have whole genome sequencing for identifying any single nucleotide substitution, it is sometimes very useful to have tests that can give us global information on the happy and on the not so happy balance of hemostasis. More and better research needs to be done before one can trustfully endorse the therapeutic suggestion flashing on the screen of a global coagulation equipment indicating the brand name of a product to be given to a patient. Thanks. Over. Questions?
Hi, that's fantastic, Dr. Rivard. Can you guys hear me well?
Yes, Dr. Brando, we hear you fine.
Okay, so maybe thank you very much for this fantastic overview of both test modalities, Dr. Rivard. Maybe I'll take the liberty of driving us through the questions again, going from west to east. Just before that, I'll remind everybody that this presentation has been recorded and it will be available on the CPT-AGN website for both PC and Mac users. So if I may take the liberty of asking if there's anybody from BC Children's joining us, if there are any questions from BC Children's? We don't seem to hear
no questions,
anybody.
sorry.
Okay, thank you. And then let's see in Alberta. I'll ask Stollery first if there are any questions from Stollery Children's Hospital.
I've got one question. It's Leslie Mitchell. It was a great presentation, Dr. Rivard. Thank you. In terms of you mentioned that the association of these tests with clinical outcomes has not been really shown. Is that the case for the all three tests you described? I don't have any, coming from the thrombosis side, we've been using the thrombin generation test for a long time, but it doesn't really correlate with risk for thrombosis. So I'm just curious as to whether there's anything that, whether these tests have been shown to have any sort of representative of risk for bleeding?
I will try and answer on half of the words I heard. Basically, I understand the question is, do we have any good clinical correlation between what we find with thrombin generation and clinical behavior or risk of bleeding? You said that you had no experience with thrombosis. Well, you probably know the answer. Unfortunately, at this point, all these technologies are interesting. There are, as you can see from the Cochrane review, very many presentation of different size and importance. But the bottom line, in all honesty, is that I don't think that at this point we can make a firm statement on the results of this and the bleeding tendency. I have to say that with the group in Burlington, we did a little study on about 30 patients with different levels of severity of hemophilia, looking at thrombin generation and looking at modeling the thrombin generation, and looking at the bleeding score of those individuals. And to our reasonably good satisfaction, there was a fairly good correlation between thrombin generation as assayed in the lab, as assayed in silico, and as compared to the bleeding score. So in short, nothing is perfect, but I think we are going in the right direction. Probably the thing that we need also is good standardization of these testing, especially for TEG more than for thrombin generation.
Thank you, Dr. Rivard. And at Alberta Children's, are there any questions?
Hi, Dr. Rivard. This is Max Steele in Calgary. I was wondering if you could maybe just tell us a bit more about the platelet mapping option for TEG. I must say I don't really quite understand what its utility is. Was the idea to look for the effect of antiplatelet agents, or perhaps to try to delineate whether a patient's got a issue with a certain type of platelet function or activation? I've always found this a little hard to understand.
Oh, I don't know if you have experience with this. We have quite much experience with this. This is we use this mainly for monitoring patients on the Berlin heart. And in fact, the company that makes Berlin heart initially was requesting that we use this. In very short, for monitoring the effect of aspirin, I would say that the test is quite good. For monitoring the effect of, say, dipyridamole, which of course is not a very good antiplatelet agent, the results are far from being satisfactory. We have no local experience with the Plavix, but I'm told by those who have used it with Plavix that there is a useful information coming from this test for monitoring the inhibitory effect of the Plavix on P2Y12.
Thank you.
Thank you. Maybe any questions from Saskatchewan Cancer Agency? Maybe we don't have a connection from there. And anybody at the Cancer Care Center in Manitoba? Maybe not. maybe we'll move to Ontario then, asking if there are questions from Chio.
No questions at our end, thanks.
Thanks, Rob, if I recognize the voice. Let's move to C-Kids. Are there any questions from C-Kids?
Hi, can you hear me? It's Walter in Toronto.
Sounds like Walter.
Hello.
All right, okay. Just one comment and then a question. Regarding the effect of platelet mapping, or we call it platelet function from elastography, we actually have quite an extensive experience here in Toronto. We've done some 30 Berlin hearts, and it's very interesting because we do, normally part of the protocol is to give Plavix, and we actually do the ADP monitoring. It's very interesting, probably about 75% of the patients are actually non-responsive to the ADP receptor, and hence they never go on to Plavix because we can actually measure this. And so Tilman Humpel, who's the guy that does it here, actually doesn't give Plavix as a result of that. So that's my comment. My question, George, is this was a great talk, by the way, is I'm interested in the subcommittee finding of the ISTH that you're recommending kaolin as the primary activator. Do you think that is because there's no standardization with corn trypsin inhibitor and tissue factor, of which we do not have a really good quality control, or is there another reason?
No, I think for the time being, the major reason is that we have nothing better that can be used across the world. Now, this is, but of course, one can argue that this is probably not the best activator, but I would say the major inconvenience to me of using kaolin is that this is not a very subtle test. This is a more or less all or none. Well, the advantage is that it makes it somewhat robust, but not very informative, I have to say. To your point of corn trypsin inhibitor, of course, this was lengthily discussed and finally not recommended for several reasons. Most of them I'm sure you're aware. One is the cost, the lack of availability everywhere, and the lack of a good standardization in terms of the right concentration. But clearly, if one is interested in using low concentration tissue factor, I guess one has to use a corn trypsin inhibitor. Otherwise, one gets a very high level of noise that makes a result uninterpretable. That's my opinion. I don't know what.
I agree with that, and we did a lot of tests, using anything from 0.5 picomolar all the way to 5, and as you say, you have to be in the lower range to make it meaningful. Otherwise, you can generate as much thrombin as you want if you put high enough tissue factor concentration. Anyway, thank you very much, Dr. Rivard. That's great.
Thank you, Walter.
Thank you. Are there any questions from McMaster? Maybe no questions from McMaster, and we'll move to Quebec. Are there questions from Saint-Justine? If not from Saint-Justine, from Montreal Children's? If not from there, from Sherbrooke? Quebec City? Any questions from IWK?
Oh, hello. It's Vicky speaking. Dr. Vada, enjoyed your talk very much. I just wanted to ask...
Vicky, can you be a bit louder?
Okay. Have you any experience with using either of these assays in trying to determine a response to FIBA versus 7A in factor 8 patients with inhibitors?
Yes. In very short, if you use a tag and add FIBA, you have a flood formation, a good reaction, a strong ME. even if you don't use the tissue factor. Now, of course, if you are using 70, you must have the tissue factor available. And of course, as you probably know, this is what led me to say that in usual circumstances, I'm not talking about the kind of situation reported by our friends in North Carolina, activation of platelets is not enough by itself to promote the generation of thrombin, at least nothing that is strong enough to be measured by TEG when one is using a reasonable concentration of tissue factor. So in other words, with no tissue factor, 70 does very little, if anything. And in short also, FABA with no added tissue factor, you can see the generation of a reasonably normal curve with a somewhat long latency or R if you're using the TEG system. I don't know if it answers your question, but clearly 70 and FABA don't behave the same in the TEG system.
Thank you very much.
Thank you. And maybe finally, are there any questions from Genuine Children's in Newfoundland? Well, as we close to the completion of the hour, I would like to thank again our sponsors for allowing us to conduct this Canada-wide WebEx. The next speaker for the session number 3 or 4 will be Dr. Manuel Carqueo, talking on the management of surgical procedures in patients with a bleeding diathesis, and we'll be announcing the date of that in April, and very closely. We will also have a 4th seminar, which will be in thrombosis. I'd like to thank Dr. Rivard, and remind you again that this will be posted on the website. Thank you very much, and looking forward to be hearing from you during the 3rd talk. Bye-bye.